Good afternoon. It's a pleasure to be here with you today. Thank you for the invitation. Almost every presenter before me already talked about non-selective His-bundle pacing, so there's little left for me in terms of general introduction to the idea of non-selective and selective His-bundle capture. So I will just concentrate on the problem: what is the importance of the direct myocardial capture that happens accidentally when we want to capture the His-bundle. So in other words, I will concentrate on what is the difference between this QRS, which is non-selective, and this QRS. Is there any difference between them in terms of clinical outcome, meaning? And I would like to begin by having a look at the scope of the problem. And if you look at the studies, single-center studies, the percentage of non-selective capture among patients with His-bundle pacing were from 40% in my AF study to 87% in Kronborg atrial AV block patient study. However, in the large group of patients from 7 centers, the data that was put together by Dan and Zach, we see that 54% of patients had non-selective capture. So it looks like this is a standard way of pacing His-bundle, even if not predominant way of pacing His-bundle. So it's going to stay with us, so better we know what it means in terms of physiology and anatomy and clinical outcomes. Simplistic way of looking at selective and non-selective pacing is that during selective pacing we have this isoelectric interval, this yellow bar that is replaced by pseudo-delta during the non-selective capture. But this is very simplistic. The truth is the myocardial wavefront that is started with the pseudo-delta goes on, and it influences the whole QRS. If you compare these two QRSs, it's not only the delta wave. You see that the amplitude is bigger, the terminal S wave disappears, so there is clearly an impact on the whole depolarization. If there is impact on the depolarization, you can imagine that it is impossible not to have some impact on contraction and possibly also on hemodynamics. I strongly believe that non-selective capture is not versus selective capture is not a 0 versus 1 or black versus white kind of situation, that there are degrees of non-selectivity. And to illustrate this problem, you have these two tracings coming from the same patient. This is position number 1, and this is position number 2 of the 3830 lead. And you see that in both positions, non-selective capture was achieved, but these are different QRSs, the same patient, the same lead, different non-selectivity. So you see this is not a 0 or 1 situation. This is 88 milliseconds time to R-wave peak in V6, and the QRS is 138 milliseconds. And the QRS seems much more narrow, and actually we even see the features of supraventricular conduction. This R prime here is the effect of background right bundle branch block that is still there, not corrected. However, in this position, the QRS is 162 milliseconds, much more broader. We see that it's much more broader, especially in lead 1 and lead V6. Time to R-wave peak in V6 is 98 milliseconds, a different QRS. And you see in V1, there is no longer R prime, that the depolarization is completely different, and the right ventricle is depolarized directly by the myocardial wavefront. Why is it possible that in the same individual we have two different non-selective QRSs? Let's look what happens when we assess the threshold in these two positions. In the non-selective position number 1, we see that we transition to selective capture. This is selective capture. So it looks that the lead is much more in contact with the His-Purkinje system than in the myocardium. However, this more ugly QRS, this broader QRS, this QRS without R prime, it transitions to myocardial capture. So it looks like this second position, the lead has more contact, more direct contact with the myocardium. And this position, this opportunity to directly engage my working myocardium impacts the degree of non-selectivity, impacts the QRS, and I believe it also impacts the potential clinical outcome and the contraction of the left ventricle. Apart from pacing, I do quite a lot of ablations, and it is hard not to notice that these two types of non-selectivity resemble very much two types of pre-excitation that we see. This pre-excitation with barely visible delta wave coming due to some kind of breach in insulation caused by pseudo-Mannheim pathway, fascicular-ventricular pathway, which is clinically not important, benign pattern on the ECG, is very similar to what we see during non-selective capture in this first position. The non-selective capture then transitions to selective very easily. Most of those patients have supraannular position, supravalvular position of the pacing lead that actually does not have any contact with the myocardium, and I believe it paces the myocardium at high output because it kind of produces breach in insulation due to virtual electrode with higher amplitude that extends to some myocardial fibers that are below the annulus, below the isolation, fibrous isolation that we have there. So this is this benign type of non-selectivity. I am certain that this kind of non-selective QRS is absolutely equivalent to selective QRS because the engagement of the local myocardium is symbolic, is subtle. However, the second type of non-selective capture, which is also resembling of pre-excitation, might be different. You see, this is one of my patients with parahesian pathway that is no longer with us, ablated some time ago. You see that these QRSs are almost identical like these QRSs during non-selective pacing with position that is infravalvular. You see lead 3, identical like lead 3 here. V2, V3 identical, precordial identical, because in both cases we have a direct engagement of a pretty big amount of the myocardium of the interventricular septum near the His bundle region, either by direct capture of the lead that is below the valve or by accessory pathway that has excellent access to it. So this is a different story. More myocardium is depolarized, more directly is depolarized. And if you look during the, for example, assessment by echograph, by peak systolic strain analysis, you can see that this ugly non-selective kind of QRS with relatively broad QRS in 1 and in V6 is not physiological. You see that it resembles a little bit RV pacing, and indeed we have some problem on the, within the left ventricle, that the lateral wall does not contract so well. There is a delay, like with left bundle branch block, delay that similar to right ventricular pacing. Why is it in this case the QRS is so ugly? Not because we are infravalvular deeply within the myocardium, but this time the answer is different. During selective pacing in this patient, when the contraction is pretty nice, we see that there is pretty long HV interval. If the HV interval is over 60 milliseconds, let's think what that means. 60 milliseconds is enough for the depolarization wavefront from the septum to reach the other side of the septum. It takes 40 milliseconds. Then there is another 20 milliseconds, so the depolarization wavefront can go as far as half of the left ventricle. So is that still His bundle pacing? Not exactly. His bundle might be engaged directly, but its impact on the contraction is not so big. And I believe that this type of non-selective pacing is inferior to selective capture. And in patients like that, I always struggle to have selective capture. Non-selective pacing in a patient like that with longer HV interval, especially if he has a lower ejection fraction, is not an option. However, if you have this minimal pre-excitation, you see the QRS during selective pacing and non-selective pacing is not that much different. There is this pseudo-delta wave here, yeah, it is there, but it doesn't impact on the QRS too much. If you look at those patients with the echo, either time to peak longitudinal strain or peak systolic strain, there is absolutely no difference. Selective or non-selective, it's nice, it's synchronous. So this type of non-selective versus selective for me is not an issue. This is just a cosmetic issue of ECG, not a contraction, not an outcome issue. Dr. Kurila, who is with us today, invited us to participate in this study, which looks at the synchrony during non-selective His pacing and selective His bundle pacing with a novel method, ultra-high frequency ECG, which is a kind of analysis of the QRS by looking only at the high frequency components. And if you see the non-selective pacing in that group was identical as intrinsic conduction, well, subtle differences, but basically what happened over the left ventricle, V3, VC7, is the same. This stands in contrast to what happens during the myocardial pacing when the asynchrony delay here is pretty big. It also shows in measures of asynchrony that there is no difference between intrinsic and non-selective. But what kind of non-selective we did have in that study? Most of those non-selective patients were pretty nice. You see this non-selective QRS is pretty nice, so no wonder there was no difference. However, some 20 or 80 patients had so-called obligatory non-selective capture, so it means that the lead was buried deep in the myocardium. And this was slightly different, had longer, bigger QRS area, and if you look at the asynchrony parameter, although this is not significant, the trend is obvious. These patients have slightly more asynchrony, which corresponds with bigger QRS area. What about the clinical data? Because the ultra-high frequency method is not well established and doesn't have clear correlation with clinical outcomes. The best clinical data that we have comes from the study by Bear and Pugal. And what we see here is the official conclusion of that study, based on, as you see, several hundred patients, is that there is no difference. However, it's hard not to notice, if you look at all-cause mortality, that there is actually a difference of over 10% in absolute mortality. This is a pretty big difference, and it's on the verge of being statistically significant. So we may say, okay, if we have a bigger group, longer follow-up, that difference may show up. Another thing is that the non-selective group here was not well matched. It was much more sicker. So maybe that was the cause of this trend that we see here. So despite the fact that this is the best study that we have that answers the question, what is the clinical importance of non-selective versus selective capture, we still know very little. That study is not enough to answer that question definitely, and we still need more data and better studies to answer that question. Another issue with non-selective capture is the thing that was already mentioned by the previous speakers. If you have a situation like that, we go down on the output and we see that there is a transition here. Something changes in the QRS, but the QRS actually changes little from 156 to 168, and we are puzzled. We don't know. Is this transition here just because of less myocardium is captured? Maybe there is loss of anodal capture or something. Is this really transition from His bundle non-selective to myocardial? We don't know. So the non-selective capture always raises a problem of how to confirm that we have a capture of the His bundle. So to answer that question, we did this study that was also mentioned, and we looked specifically at QRS features of non-selective capture. The idea was very simple. The QRS, when we have a His bundle capture, selective, non-selective should be nicer. And we all see that with eyes, that it is nicer. So, but to see and to prove that what you see does really have a diagnostic value are two different things. So we looked systematically at certain features like how narrow is the QRS, whether there are notches or not, whether there is a plateau, how far it is to the R-wave peak, whether they have diagnostic value, and yes, they have very potent diagnostic value. So this is one way to approach the non-selective capture in the ECG. If you see notches, if you see plateaus, if you see slurs, if you see broad QRS or delayed R-wave peak, most likely this is not non-selective capture, but just RV capture. And even if it is non-selective capture, probably the delay because of the long HV interval, probably the intraventricular delay because of non-corrected left bundle branch block of non-specific conduction problem within the left ventricle is big enough that the fact that you capture the His means little. So when you see these features that you see in this upper panel in the ECG, you can say to yourself, this is not non-selected, this is not His bundle capture, or the His bundle capture is very poor and probably not important clinically. So that's the one way of looking at this situation. And it impacts on the answer to our question, is non-selective capture inferior or not? If we had selective capture, we wouldn't have to think about that because selective capture offers straightforward diagnosis whether we have His captured or not. Non-selective capture is inferior in that respect because we don't know that obviously. Sometimes situation may be even worse. Not only the transition may be, like in the previous example, not so straightforward to analyze, sometimes there might be no transition at all. As previous speaker showed to you, such cases occur in 5, 7, 8% of our procedures. And then if we have a QRS like that, this blue one, pretty broad, not so nice, even notched in one lead, you are not sure. And there is no transition. You are not sure, did I capture His bundle? Should I prolong the procedure, or is that enough? And then you can use the programmed His bundle pacing method to really provide the answer. And this method is nice because it can actually provide you with the information why this QRS is the way it is, because you can visualize both components of this fused QRS. With short coupled impulse, you can visualize the myocardial component, pure myocardial component, but using the single extra stimuli or double extra stimuli during intrinsic rhythm, very often you can get selective response and see selective QRS. And right now, you know that these two QRSs together make the non-selective QRS. And you can somehow see the impact of each of these two QRSs on the final QRS. And here you have also the answer why this QRS is so ugly, because the time from the stimulus to the QRS, the HV interval is pretty long. And this is why this non-selective QRS was not so nice. You have now the answer. But again, that method, which is very nice, would not be necessary at all if we had only selective capture, which is diagnostically straightforward. So again, non-selective seems inferior in that aspect. And one more thing. This is a patient who had, for many years, RV pacing and absolutely no sign of old myocardial infarction in his ECG. But when he was upgraded to His bundle pacing, it became obvious that he had pathological Q wave here, 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 and here during selective pacing. He indeed did suffer myocardial infarction, and that is diagnostically obvious during selective capture. But what happens during non-selective pacing? What happens with this Q wave? It disappears. What happens with this Q wave? It disappears. So you see, well, it is still present in some leads, but in some it is not. So again, you see that the non-selective capture not only poses a diagnostic problem, not only poses a question whether the contraction is really physiological, it also impacts on our ability to use ECG as a diagnostic tool, for example, when you look at ischemia, both acute and old myocardial infarction, because repolarization and depolarization is influenced by non-selective pacing. So again, non-selective pacing seems a little bit inferior to selective capture. Well, in conclusion, firstly, I do not have the answer to the question of my lecture. I don't know whether selective or non-selective is better because we have no proper data really to answer that question very well. However, I believe that selective and non-selective is not a 0 versus 1 situation, that there are degrees of non-selectivity, and that this is the most important thing that a practical implanting physician should realize, that he can be happy with slight non-selectivity and don't disregard it, but he should consider seriously when the non-selectivity is big, when the QRS is broad, when there is a notch, or when there is a huge delta. Well, it is also obvious for me that there are significant differences between non-selective His bundle capture and selective His bundle capture in several areas. Electrocardiographical differences we discussed, and they are obvious for everyone. Well, they come from electrophysiological differences. certainly the activation of the left ventricle and right ventricle would be different during selective and non-selective pacing. Well, there are also echocardiographical differences, not in everyone, but in some, as you have seen on the example. That might, or most likely does, translate to some, maybe subtle, but some hemodynamical differences. So far, we have no good data for that, but I'm sure that the patients with broad QRS during non-selective capture would have inferior hemodynamical hemodynamics of the heart. It also translates to practical differences, like his bundle capture diagnosis in the ECG, like myocardial ischemia assessment in the ECG. Whether this translates to clinical outcome, because this is probably the thing that is most important, and the answer to that question is most important to us, I don't know. And because I don't know, I think that we really still need a large multi-center study that would answer that question, a study that would first have matched non-selective and selective groups, a kind of propensity score analysis, from multi-center, large groups, and matched. And the second thing is that study should look at the degrees of non-selectivity. There should be a group with broad QRS complexes, non-selective, and narrow QRS complexes, non-selective. And then, when such a study is performed and published, I would be able to answer the question of that lecture. Thank you very much.